Hello and welcome to my presentation. Today I'm presenting on diabetes type 1. So, welcome to the session. Overview of diabetes mellitus type 1. Saying that this is a chronic endocrine disease characterized by absence of insulin produced by the pancreas, resulting from autoimmune destructions of beta cells. So, guys, beta cells are the one responsible for production of insulin, and in this case, beta cells are destroyed. So these conditions normally affect the carbohydrate, fat, protein metabolism, resulting in a situation of hyperglycemia. This condition requires long-term medical condition to limit end organ complications, which ranges from accelerated atherosclerosis, neuropathy, nephropathy, and retinopathy. It's important to note that diabetes type 1 requires a lifelong insulin therapy. Diabetes type 1 is the seventh leading cause of a disease in leading nations such as United States, along with heart diseases, cancer, COVID-19, accidents, stroke and cerebrovascular accidents, chronic lower respiratory diseases, and Alzheimer's disease. It's important to remember that diabetes type 1 was previously known as juvenile diabetes or insulin dependent diabetes. Currently, diabetes type 1 is also abbreviated as T1DM. On pathophysiology of diabetes type 1. We are saying that autoimmunity is considered the major risk factor in diabetes type 1, placing beta cells at special risk for inflammatory damage. In this case, human leukocyte antigen, that is the HLDR3 and DR4, which are specific markers for type 1 diabetes susceptibility, have been found in about 95% of all the patients. So this makes it the major cause of beta cell destruction. Also, we have amino acid metabolism and low vitamin D levels, which may play a role in pathogenesis of type 1 diabetes. Type 1 diabetes may result from damage to pancreatic beta cells from the infectious or environmental agents. An autoimmune response against altered pancreatic beta cells antigens, the presence of anti-insulin antibodies or a combination of these factors result in the destruction of beta cells, which eventually results in reduced production of insulin hormone. So most isolate cell antibodies are directed against glutamic acid decarboxylase, abbreviated as GAG, within pancreatic beta cells. So in summary, for the pathophysiology of diabetes type 1, we have lymphocytic infiltration and destruction of insulin-secreting cells of the islets of Langerhans result causing low levels or absence of circulating insulin. Okay, and when you have low levels of circulating insulin, results in elevated levels of plasma glucagon and failure of pancreatic cells to respond to stimuli. So, ladies and gentlemen, here we have the pancreas, and here we are looking at, we're trying to compare it between the normal pancreas and the abnormal pancreas, or a pancreas in the case of diabetes. So, on my left, you can see the pancreas normally produces insulin. The insulin combines with the glucose and it drives this glucose into the cells. Okay, as a result, insulin moves the glucose into the cells. This is compared to in the case of diabetes, where immune cells destroy beta cells in the pancreas. As a result, pancreas cannot produce insulin. And what happens then? So more glucose will remain circulating in blood. Okay? So the cells are going to starve, not receiving glucose, and majority of glucose will remain in blood. Okay? Resulting in a situation that we refer to it as hyperglycemia. Very good. What are the causes of diabetes type 1? Well, we have genetic inheritance with an increased risk associated with the presence of both human leukocyte antigen DR3 and DR4. We also have immunologically medicated the destruction of beta cells by the enterovirus infections, the viruses, mumps, rubella, cytoxins, toxic chemicals, exposure to cow milk in infancy, or a combination of these factors result into destruction of beta cells, predisposing one to what? Diabetes type 1. We also have treatment with antivirals or immune checkpoint inhibitors. These are immunotherapies are cancer treatment that aim to stimulate the immune cells to kill cancer cells. The stimulating effect can cause high blood sugar levels for people who have diabetes. We have infant weight velocity, and you're saying that these are changes in measurements or increments in weight and height or length from one visit to the next. Okay, so we say that normally we have an increase of 2.5 centimeters per month between birth and 6 months. Then we have 1.6 centimeters per month from month 7 to month 12. And then finally, we have 7.6 centimeters per year between month 12 and 10 years. It's important to note that we are able to estimate the height of an individual at 2 years, since at 2 years they have already achieved half the adult length. In terms of weight, it's good to know that the weight will double at 6 months and then will triple at 1 year. Very good. Let's look at the next cause, and this is diet high in nitrosamines. We're saying that nitrosamines are non-carcinogens and can also damage beta cells in the pancreas that produce insulin, contributing to diabetes type 1. Finally, on the causes, we have environmental toxins. And you're saying that environmental toxins such as viruses, diet, or chemicals may trigger the disease in genetically predisposed people. Okay? Thank you. Let's look at risk factors for diabetes. We are saying that a certain human leukocyte antigen, especially if we talked of the DR3 and DR4, presence of molecular weight protein, which normally is responsible for antibody formation. We have family history of type 1 or type 2 for that matter in any first degree relative. Okay, we have slightly greater risk for a child if the father has a type 1 diabetes. Okay, the child is likely to suffer from the disease. We also have exposure to Epstein-Barr viruses, mumps, rubella, cytomegalo. Both contribute to the destruction of beta cells responsible for production of insulin. What about treatment with antivirals or immune checkpoints? Yes, we just said that when production of such, we say that they are cancer treatment that aim to stimulate the immune system, that is to kill the cancer cells. So this stimulating effect can have high blood sugar levels for people who have diabetes. Okay? Second last, we have exposure to cow's milk at an early age. And they say that it could be that in some predisposed children, early exposure to cow's milk could trigger an immune reaction to insulin. Okay? So the insertion of insulin-specific T cells by dietary insulin in the gut immune system may carry a risk for an autoimmune process, progressing ultimately to clinical type 1 diabetes. The other factors include maternal age younger than 25 at birth and preeclampsia during gestation. What about incidence? We are saying that in developed nations such as United States, we have 28.7 million people have been diagnosed with DM. And out of this, approximately 6% have type 1. So guys, when you try to compare type 1 and type 2, you find that the type 2 is more common, right? Very good. Very good. What are the complications of diabetes type 1? We have chronic foot ulcers, venous stasis ulcers, lower extremity amputation, hypoglycemia, hyperlipidemia, microvascular disease involving the coronary, peripheral vascular disease, and cerebral artery disease, microvasculature disease, referring to retinopathy, nephropathy, and neuropathy. We also have the major diabetic ketoacidosis, and we'll be able to compare this DKA and HHNS. Okay, the link is going to appear. You can click on it and try to see the differences between. We have excessive weight gain, weight loss, skin and mouth complication, particularly gum infection, osteoporosis, hip fractures, pregnancy complications, including increased risk of preeclampsia and preterm delivery, hearing impairment, and staphylococcal sepsis. Okay, it's also common knowledge that patients with chronic disease do present with psychological problems that needs to be sorted, including depression, anxiety, and some of them that the one actually that affect the quality of life of patients. On assessment, we have history and physical findings. On history, this is what we gather from the patient. Physical finding, this is what we get through the physical assessment techniques. So in assessment, possibly we could get that this is a DKA as is the initial presentation for this. Most patients are not aware until they are diagnosed of this complication. We have also polydipsia, polyphagia, increased fatigue and lethargy, muscle cramps due to electrolyte imbalance, vision changes, abdominal discomfort, nausea, and changes in bowel, recurrent skin infection and rashes, including vaginal yeast infections, anxiety attacks, irritability, emotional liability, headache, altered school or work performance due to that element of psychological challenges. Okay? Lastly, we have peripheral neuropathy, numbness and tingling in the hands and feet and a glove and stocking pattern, bilateral, symmetrical, and ascending neuropathy. What about the physical findings, the ones that we get them through the assessment techniques? We have the orthostatic vital signs, where a patient when lying flat, the vital signs are okay, but when they rise up, this is changes, significant changes in vital signs. Kussmaul respirations, especially when we have DKA and the patient has deep, brief, yeah, respirations that are very rapid. Okay. You have possible retinopathy, and these patients they need ophthalmologic review. Possible foot infections with possible absence of dorsalis pedis and posterior tibialis pulses, especially in peripheral artery diseases. Okay, we have possible peripheral neuropathy in the lower extremities in patients with foot ulcers. We have skin infection such as staphylococcal infections, okay, and other fungal infections, okay. We have lower urinary tract infections, very common, especially infections in the bladder and the urethra. Lastly, we have malignant otitis externa, okay, among others that mainly affect arise as a result of DM. On diagnostic test results, we'll be looking at laboratory and other imaging techniques that will also help us to diagnose diabetes. Number one, we have fasting blood sugar. Okay, and this fasting blood sugar, of course, is normally gotten after at least 8 hours without food. And in this case, it should be equal to or more than 7.0 milliosmoles per liter. Remember, we had discussed and we say that you can easily convert milligrams per deciliter into milliosmoles per liter by simply dividing it by 14. We also have oral glucose tolerance test, and this is usually equal to or above 200 milligrams per deciliter. This is synonymous with the 11.5 milliosmoles per liter. And just saying that during this case, we should use 75 grams of oral glucose tolerance test. Okay, great. The third one is random blood sugar level of greater than 200, and in the presence of symptom. This is usually in the presence of symptomatic hyperglycemia. This one could also be indicative of diabetes mellitus. We also have a test that can be used or can give a count of a longer period, like of 3 to 4 months, okay? And this one we call it the HB1IC, hemoglobin IC, okay? And this one is saying that the level should be greater than or equal to 6.5 for it to be indicative of diabetes mellitus. So a positive titer of a GAD antibody suggests type 1 antibody and type 1 diabetes, except in a patient with type 2 who has hyperglycemia, okay? And this should be over 300 milligrams per deciliter. All right. We have also other findings like serum electrolytes may be elevated, especially with ketoacidosis. We have urinalysis may reveal glycosuria, ketonuria, and microalbuminuria. Then you have CBC, which with differential may reveal an increased white blood cells and hemoglobin level. Up to treatment. In treatment, guys, we'll be looking at general treatment, diet treatment, activity treatment, medication, and surgery. And lastly, nursing process. On general, we are saying that the blood sugar control should include an individualized glycemic target and blood glucose control measures. Individual best. Risk reduction for macrovascular problems, especially the blood vessels affecting the heart, brain, and peripheral vessels. We also have lifestyle adjustments, okay? Like smoke cessation, achievement and maintenance of health body weight, okay? Self monitoring of blood glucose, evaluation and treatment, okay? Evaluation and treatment by ophthalmologist, and psychosocial problems and screening due to the chronic nature of this disease. We're reminded that we need to evaluate the cognitive capacity throughout the lifespan. We need to avoid avoidance of hypoglycemic episodes and prevention of acute complications such as ketoacidosis and delay and prevention of other chronic complications. Venous thromboembolism is also an issue, and prophylaxis if the patient is hospitalized. That should be the case. We have guiding principle for diabetes mellitus. We say that for patients with diabetes mellitus, for you to improve their quality of life, you need to identify and diagnose diabetes and pre-diabetes. You need to manage pre-diabetes and prevent type 2 diabetes. You need to provide individual or patient-centered care. Okay? You need to provide self-management education and support, encourage lifestyle modification to enable the patient at least a control of the sugars. You need to manage overweight and obesity, and here you are using the BMI and MWAC to measure the recommended weights. You need to control blood sugar levels to avoid these complications. You need to reduce cardiovascular disease risk, okay, by managing cholesterol, hypertension, the ones that are closely related with diabetes. We need to detect and monitor microvascular complications. And lastly, we need to consider the needs of special population, and special attention should be given to population who are at increased risk for developing diabetes. Thank you. So after looking at general treatment, we look at now the diet. Very good. So in this case, the nutritionist will be of valuable help here. And you're saying that for nutritionists, they need to consider the different food chemicals. Okay, so carbohydrates should be checked closely and should include fiber. Okay, yes. Carbohydrate intake should focus on high quality, nutrient dense carbohydrate sources that are high in fiber and minimally processed. Okay, we want to avoid processed food because they may not be good for our patient. When consuming a mixed meal, okay, that contain carbohydrates and other food components, and giving insulin for that matter, we need to consider also the other food components and not just concentrate on carbohydrates. Decrease consumption of sweetened and non-nutritive sweetened beverages, and also increase the water intake. On activity, we are talking of regular exercise. We are saying that diabetic patients should ensure that they exercising of not less than 150. Okay, should be more. Okay, they should exercise at least 3 sessions in a week, and these sessions should not be consecutive. Okay, they should be non-consecutive. We need to reduce or decrease time spent on daily sedentary behavior, interrupt these processes every 30 minutes so as to at least improve circulation and put them under control. Okay? What about medication? You're saying in this patient of type 1, we are going to be put on insulin. Okay? Insulin. So we could have rapid acting insulin, insulin lispro, glycerin, and aspart. We normally abbreviate it as LAG, L-A-G, lispro, aspartate, and G. We also have short-acting insulin, okay? Regular insulin, we normally abbreviate it with R. So we have R for that one matter. We have intermediate insulin, such as isofen insulin suspension, neutral, protamine, hectone. Okay? We'll always have N. Okay? Always have N on such. Then you have long-acting insulin. You have glargine and demetamar. Okay? Great. Remember that these ones are the ones that not mixed with the others. Okay? Okay. We also have glucagon is the antidote of insulin to increase levels. Okay. Remember, this one you're going to use to boost glucose. especially in the cases where our patient will be unconscious. Because if conscious, then they can be given something to eat. Okay, then the immunization will be provided based on the guidelines. Lastly, we have surgery, and you're saying that there is a possible plantation, particularly transplantation, especially or particularly when you have this simultaneous kidney transplantation for the end stage renal disease. Others, thank you guys. Thank you for listening. It has been a pleasure. You can pick it from there. Thank you.